Welcome to the Healing Dementia Summit. I'm your host, Dr. Sharon Goldberg, and today I am truly honored to be interviewing Dr. Dale Bredesen. Dr. Dale Bredesen received his undergraduate degree from Caltech and his medical degree from Duke University. He was a postdoctoral fellow in the laboratory of Nobel laureate Professor Stanley Prusiner, then held faculty positions at UCSF, UCLA, and UCSD. He was the founding president and CEO of the Buck Institute for Research on Aging, where his laboratory studied mechanisms of neurodegeneration and published over 230 scientific papers. This research led to the first report of the reversal of cognitive decline in Alzheimer's disease. Dr. Bredesen is the author of 3 New York Times bestsellers and currently serves as the senior director of the First Precision Medicine Program for neurodegenerative diseases at the Pacific Neuroscience Institute. You can learn more about Dr. Bredesen's work at his website, drbredesen.com, drbredesen.com. Dr. Bredesen, welcome.
Thanks so much, Sharon. Thank you. Great to talk to you.
It's great to be talking to you. I have so many questions for you. We're just going to dive right in. Dr. Bredesen, is cognitive decline is the cognitive decline associated with Alzheimer's disease reversible or not?
Absolutely. And so this has been a schism in medicine. There's been this argument that the classical approach, you wait until fairly late and then you give a drug and it just doesn't do much and people die left and right. That all has changed. And I think this is something that's so important for people to understand. Now, yes, if you wait later and later, that's a problem. But for many people, in our published trial, freely available online, published trial in Journal of Alzheimer's Disease 2022, 84% of the people that were treated improved, didn't just slow their decline, they improved their cognition. We've also recently published the first examples of people who improved and sustained their improvement for over a decade in some cases. And then in the current trial, we're seeing almost everybody improve their scores over time. So the world has changed, the entire world of looking at dementia and pre-dementia. And I think it's very important to say, just like with any chronic illness, like cancer, you have a period where you have no spread of the cancer and it's much easier to deal with. And then you have a period where there's local spread, it's less easy to deal with. And then you have a period where there is widespread metastasis. Well, Alzheimer's is very much the same idea. There are 4 phases. The first phase, you're asymptomatic. In those people, we have never seen anyone where they got on appropriate prevention and yet they still became demented. We've not seen it. So it's pretty easy if you do the right things to prevent the problem. The second phase is called SCI, subjective cognitive impairment, and the epidemiologists have shown that lasts on average 10 years. By definition, that means there's something wrong, things aren't the way they were, but you're still able to score in the normal range on cognitive testing. So that's SCI. Virtually 100% of those people will get better if you look at what's causing it, you address the various causes. And there are typically multiple contributors. It may be insulin resistance, it may be a leaky gut, it may be poor oral microbiome, sleep apnea, recent COVID. Just go down the list. There are dozens and dozens of things. You have to look for them and address them. The third phase, which is where the trials are typically done in the 3rd and early 4th phase. So already you can do even better than those. So the third phase is MCI, mild cognitive impairment. And as one patient said, there's nothing mild about it. Unfortunately, it is the 3rd of 4 phases. And by definition, then you are not scoring normally on cognitive testing, but you still have your activities of daily living intact. And then each year, 5 to 10% of the MCI patients will progress to the 4th phase, which is dementia. And there's where you are losing your activities of daily living. We've seen people, even with MoCA scores of 0, improve. But when you're in that dementia phase, the improvement is to dress yourself again, speak again, become continent again, things like that. It's not all the way back to normal. So we encourage people, please get in those first 2 phases if you can, either with prevention, if you're 35 years of age or older, It's a great idea to get on prevention because we now know that these changes start at least 20 years before diagnosis. In fact, there are two papers recently showing changes in the brain in the 20s, the earliest pathophysiological changes. Or at the SCI phase, if you don't do prevention, get in early, get optimal treatment. So there's no question we have documented and published repeatedly, as other groups are beginning to do, like Dr. Heather Sanderson, who did her own clinical trial, published very much the same results as ours, with most of her patients undergoing improvement in their cognition. So we no longer can deny this. Yes, there is reversibility of cognitive decline, and the earlier you start, the easier and more complete it is.
And what a great explanation of the different phases. It's such an important point because so many people hear from their conventional physician or their neurologist that, no, there's nothing you can do, or they'll say there's no evidence. But what you're saying is the whole question is, how do we decide if something is fact or not? There's research, and you can look to the medical literature and you can back it up, right? So what you're saying is there absolutely are multiple publications that attest to the fact that dementia and cognitive decline are reversible. Is that
absolutely? Now, at each stage, people have said, so when we first published the first 10, they said, well, that's not enough people. So then we published 100. Then they said, but that's not a trial. So then we did a proof of concept trial, and then another group did it with it, both very successful, both showed improvement. So we are just finishing a clinical trial, a randomized controlled trial at 6 different sites around the country. And we have 95% of the cognitive data back already. And already we can see it has a larger impact than any previous trial. And in fact, the group in the control, which is standard of care for Alzheimer's, is going down, just as we've always known they do. And the group being treated is going up with their cognition. So there's just no question. There's peer-reviewed, published literature showing that indeed cognitive decline is reversible.
amazing? And how many patients are in the most recent trial with the 6 sites?
So I'm so glad you brought that up, because this is another thing, another criticism. They say, well, these other trials have 1,500 patients. Yes, because the effect is so tiny when you're looking at going down fast or going down slightly less fast. You can't get a statistically significant difference unless you do 1,000 or more patients. And so we've actually compared the effect size. So we have a wonderful statistician, Dr. Stephen Ada, who's doing all this analysis of the trial, and he's looking at effect size. And in fact, the effect size of this trial is greater than any previous trial. It is 6.5 times the effect size of lecanemab, called Leqembi, where there was a minimal effect, which just slowed. So yes, they had to use 1,500 patients. So before we start this, of course, we look at how many will it take, given what we know about the effect approximately, to get a statistically significant difference. And so it came out to be 50 patients. We ended up doing 70. So we have 73 who entered the trial, and then several dropped out during the time. They didn't want to do pieces of it, but the vast majority finished it. And so the number was 73. And again, that's not a huge number, but it gives a highly statistically significant difference because the effect size is so large between treatment with the protocol that we use versus treatment with standard of care for Alzheimer's disease.
That's incredible. And when do you expect it to be published or
Yeah,
finished?
so there will be a preprint posted in December, and then there should be a peer-reviewed publication in about April. It depends on the reviewers. If they want lots of changes, it'll be more like May or June. If they want few changes, it could be more like March.
Got it. Incredible. So essentially, Dr. Bredesen, you've taken really a systems-based functional medicine type model and really honed it with this laser focus towards cognition. And one of the real hallmarks, the things that I feel is so important, is the way that you describe these 6 different subtypes of dementia. And essentially, it's saying that dementia is not one disease, but it's many things going on. Could you I'm hoping you could talk a bit about those different subtypes and how they help with your treatment.
So when we started looking at people who were developing cognitive decline, and we started doing more of a deep dive into their genetics, their epigenetics, their biochemistry, what we could see is they weren't all the same. And what we found was there are some where the major problem is an inflammatory one. So anything that gives you systemic inflammation is going to increase your risk for cognitive decline. And no matter how you get there, ultimately, this is a network insufficiency. You have this remarkable network of 500 trillion synapses in your brain, and it's got to have energetic support, mitochondria, blood flow, oxygenation. So, if you have sleep apnea, that's putting you at increased risk. And then if you've got any sort of inflammatory component, that's making it tougher because now the demand. So your supply goes down if the blood flow or the oxygenation goes down. Your demand goes up if you have inflammation or toxicity. For a lot of toxins, it's both. They reduce your supply and they increase your demand. So that's a double whammy. So anything that affects that balance can lead to this chronic network insufficiency. So we found that there are a lot of patients where they are inflammatory. And interestingly, these groups look different. The inflammatory ones are typically could be a man or woman. It's typically they're in their 60s. They've got inflammation from metabolic syndrome or from various infections or things like that. Poor oral microbiome is another one. Chronic sinusitis, tick-borne illnesses, all of these things. They often look inflamed. Their HSCRPs are often high. So all of these sorts of things. And I know at the recent PLMI meeting, there were some wonderful talks, Dr. Eric Lundquist and others talking about SII and SIRI as wonderful metrics, simple metrics from a CBC, from complete blood counts, to look at underlying systemic inflammation, which I think is a wonderful idea. So that's type 1. Type 2 is very different. These are people where it's atrophic. They don't have the hormone support. They don't have the nutrient support. They don't have the growth factor support. It is more of what the Ayurvedics would call a drive. By the way, we published these different types, and it turned out Ayurvedic medicine noted these same subtypes thousands of years ago. So we thought, hey, we're way ahead of the game. We noticed this. No, this was published thousands of years ago. People noticed that these different things give you dementia. But the good news is when you find them, now you know what to do about them. So these are people, and the typical patient that I see with the atrophic, it's a 75-year-old woman. And it's interesting, when you have the atrophic subtype, you tend to you do pretty well for a longer period of time. They play tennis, drive their cars, doing great. They do whatever they're doing in their lives. They just are having trouble learning new things. And their spouses will often say, she's fine, but we were at dinner last night. She asked me the same question at the beginning, in the middle of the dinner, at the end of the dinner. Something has changed. Her memory's not what it was. That's the atrophic subtype. And they do very well with supporting that neuronal, the synaptic tree. And then there's one that's in between those two. So we called it type 1.5 because it has both. It has inflammation and it has an atrophic effect. And that is glycotoxic. These are people who have insulin resistance. 100 million people in the US have insulin resistance. So it's an incredibly common problem. So the fact that they're not responding to insulin well anymore gives them the atrophic part, because insulin is a very good neurotrophin. In fact, in the lab, when we used to culture neurons in dishes, you always have to include insulin in the dish to keep the neurons alive. So it is quite a good factor for a neurotrophic factor. But at the same time, when your glucose is now going up, you now get non-enzymatic glycation of proteins. So these various proteins have glucose stuck to them, like remoras on a shark. And so you're now getting an inflammatory component due to that. Of course, we measure this as hemoglobin A1C, but there are hundreds of proteins that have glucose non-enzymatically stuck to them. So that's type 1.5 glycotoxic, very common. And then type 3 is completely different. And these people look different often and act different. And this is toxic. And these people are exposed to one of 3 different types of toxins. It's either the inorganics, air pollution, mercury, things like that, or the organics, microplastics, anesthetic agents, common one, benzene, toluene, all the glyphosate, all these sorts of things. Or it's the third type, which is the biotoxins. And that's from mycotoxins like trichothecenes, ochratoxin A, very common. And these people often look different. This is the 52-year-old, and this also is more women than men. Of course, Alzheimer's, it's about 2 to 1 women to men. So as Maria Shriver has said, this is a woman-centric disease. About 65% of patients, about 60% of caregivers are women. And so it's often around the time of menopause. And because at that time you have more difficulty dealing with toxins, and these things that have been in the bone are now beginning to come out of the bone. So you have a reintroduction of systemic toxicity. So again, you need to identify them. You need to detox to get the best outcomes from these various toxins. That's type 3. These are often ones that have a non-amnestic presentation. Instead of starting like type 2, these people typically have trouble with their memories. Type 3 often have trouble with executive function. They have trouble with recognizing faces or other visual analysis. They may have word finding troubles. It's often, and by the way, they often start with depression as the initial finding, and then they'll be treated for depression. Then someone says, wait a minute, they're getting demented. So that's type 3. That is the toxic. Type 4 is vascular. And so these are the people that we see all the time with very poor lipid profiles. They also often have some systemic inflammation, but their main problem is they're not supplying the brain with enough blood flow. And these are where things like exercise, and especially things like EWAT and KATSU, can be very helpful for them. And then the final—
Just tell our listeners what those two things are.
EWAT is exercise with oxygen therapy. So it gives you a double boost. You've got the exercise part, more blood flow, but you've also got the oxygenation part. And so you're now really reaching more areas of the brain with oxygenated blood. So that's been very helpful for a number of people. KATSU is one that actually improves your muscles, and these are these restriction bands. So it makes it so you essentially get more bang for your buck, and especially for us older people. I'm in my mid-70s now. So for us older adults, if you're concerned about things like damaging tendons and ligaments and pulling muscles and things like that, KATSU makes it so you don't have to do as much exercise to get the same good outcome. And of course, improving musculature is very helpful. It improves your insulin resistance. You get more insulin sensitive, among other things. So that's all helpful for the exercise piece. So the final one, which is type 5, is traumatic. And we see it all the time, although we tend to think of trauma as associated with CTE, chronic traumatic encephalopathy, which does happen sometimes, which also has the same molecule tau that Alzheimer's does. But Alzheimer's is amyloid and tau, and CTE is just tau, typically without the amyloid. There's no question. In fact, there have been some studies done showing that people who have head trauma will have amyloid right after that. So it is part of the healing. It's part of the response to head trauma. And no question, it can increase risk. And that's been published by many groups. No question, head trauma increases risk for cognitive decline. Now, I should mention, because you mentioned different types of dementia, this is all, what I'm talking about is all ultimately Alzheimer's disease, which is the major cause of dementia. There are other causes of dementia that are not Alzheimer's: frontotemporal dementia, Lewy body dementia. In fact, we've seen very good results with Lewy body dementia with the protocol we developed for Alzheimer's. Lewy body is basically, it's related to type 3. It is a toxic related, but instead of the amyloid and tau, you have alpha-synuclein, which is a different molecule. Both of these molecules, amyloid and synuclein, and in fact, tau, all three of them, they're all antimicrobial peptides and proteins. They're coming because you have insults to your brain.
It's so helpful to hear about the different types. And I know that what families will say is that it's very overwhelming to hear about a functional medicine or a multimodal approach to improving cognition.
Yes.
And I know that you've been involved with a company called Apollo Health. So what I'd like to know is, could you just tell us, how does this look? Why did you get involved with this company? And
Yeah.
what are the services that they provide to families and caregivers who would like to dip their toes into this approach, but maybe don't have a functional medicine physician yet or aren't going to be able to work with one?
Yeah.
What are the services that company offers?
Yeah. So what we're doing all came out of the lab. So I ran a lab for 30 years looking at the basic mechanisms that drive the neurodegenerative process. Why are neurons dying? Why are synapses being lost? All this sort of stuff. And we realized over time that the classical model of Alzheimer's as being due to amyloid was wrong. That in fact, this is a network insufficiency. As I mentioned, you've got all these things that support it, which is not surprising. Yes, you've got this incredibly complicated system in your brain, and of course you've got to support it. And of course, you can't demand more than it can give you. Of course. So now we realize, okay, there are many things. So originally we looked at how many mechanisms were underlying this, and we found 36. So I always say to the patients, imagine you have a roof with 36 holes in it. A drug is a wonderful patch for one hole. But what about the other 35? So you do have to take a precision medicine or functional medicine sort of approach where you're looking at all the drivers of the problem. And so if you've got insulin resistance, you got to address that. You got to get insulin sensitive again. If you don't have to address that piece. So these are personalized protocols that are simply based on what do you find. So when we started looking at this, we realized, okay, we have to find a way to test for all these and then to address them. I would do the first patients I saw, which was back in 2012. It would take me 2.5 hours per person to go through all the different pieces and say, okay, we have to fashion a treatment for you. Okay, it's going to have this and this and this. And don't get overwhelmed. Just take one at a time. Just take one, do that for a few weeks. Now add the second one, not a problem. But you're going to have all these things. So we realized we need to have a computational algorithm. We need a group that actually brings all this together, that can produce a community. What I love about Apollo, and this is a group from Apple, the guy who runs Apollo is Lance Kelly, along with Sho Okada. They've got a great team, and they are originally from Apple. And so they are very good at bringing together large sums of data. And in fact, we just recently have posted, and then now it's going to be published, a paper. It's freely available online. You can look up at preprints that when you do this protocol, you actually improve depression as well as dementia. So we're very enthusiastic about that. And that came out of the data from Apollo. You can actually now start following thousands. There have been over 10,000 people now that have come through the protocol. We've trained over 2,000 physicians from 10 different countries and all over the US. So what Apollo does is it creates a community of people that help each other. And secondly, it allows us to capture data so that we can see who's doing better, who's doing poorly, so that we can continue to enhance the outcomes, so we can improve the outcomes. And it provides a simple way to get your blood tested. We started with what's called RECODE labs for reversal of cognitive decline. These are labs that look at all the things that drive cognitive decline. Recently, we've added the second group, which is called Brain Scan, and it gives you your p-tau, your GFAP, and your NFL. Now, why is it so important to check your p-tau? And by the way, I just checked mine. I had it done at my kitchen table. You can have mobile phlebotomy, or you can go to a local draw station. It's really helpful. If you know your blood pressure, and if you know your glucose or your cholesterol, you should know your p-tau 217. And the most sensitive one is from this group, Neurocode, which is part of this brain scan. And so you get this drawn, and what it does is it will tell you, are you on the side of the signaling? Is your supply too low and your demand too high? And so essentially you can see it coming. It's a little bit like 50 years ago, people started doing hemoglobin A1C. So now you don't have to wait to have diabetes. You can say, oh, okay, you know what? I'm heading for pre-diabetes. I better address this now. And I can avoid the retinal damage and vascular damage and kidney damage of full-on diabetes. It's been a fantastic advance, hemoglobin A1C. And so now we can do the same thing in the brain. We can look at your p-tau 217 and say, are you in great shape, or are you beginning to head in the wrong direction? So let's get you back there before you have any significant problems. With all these new advances, there should be very little dementia. We no longer have to wait for dementia to happen. This, again, for my generation, this was the biggest fear of my generation, that we would develop dementia, because it impacts so much of your job, your life. It's a terminal illness. Your family's impacted. It's horrible. So now you don't have to wait for that. You can see things early. You can do something about it and never get to the dementia stage, which is just a huge advance. Now, the other two markers, GFAP and NFL, give you complementary information. GFAP is for inflammation and attempted repair in your brain. It's, instead of the neurons part of the brain cells, it's the astrocyte part of the brain cell. It's the glial cells that support the neurons. And so you can see, are they turned on with inflammation? That's the GFAP. And then you can see that the NFL is neurofilament light. That says, is there anything that is actively damaging my neurons? Doesn't have to be Alzheimer's. It could be a head injury. It could be frontotemporal dementia. It could be vascular disease, whatever. So if you've got 3 normals on there, you're in great shape. And then you should recheck in about 5 years. You don't have to get it every year. If you're over 60, you probably want to recheck in 2 years. So mine came back normal. I was very happy to see that. 2 years, I will recheck mine again. And look, if they start bumping up, don't worry about it. Get on active treatment and you don't have to worry. So this is really a new era when it comes to preventing and treating dementia and pre-dementia conditions.
And so I'm going to back you up a little bit. And I'm asking about this because I really don't know. And I want to know for the listeners, because I do know that Apollo has offers a lot of services to people. It's a direct to consumer kind of a thing. So let's say that I have a parent who needs some help. How does that, if you could just walk us through how this works, do they sign up for a membership, or is it just the labs? Or I want to understand the nuts and bolts of how, because there are coaches, right? And
This is such a great point. So again, what's been put together is a community. What we noticed at the very beginning is when people came together, the first couple people, Dr. David Jones drove them down in his car from Oregon. When he realized, hey, we're reversing cognitive decline, he would put people in his car and drive them down to the Buck Institute where my lab was. And we would go over there, and we noticed immediately people would talk to each other. Hey, I did this and this, hey, what about this? So this is a community where there's sharing. Julie G., who is herself an ApoE4, so she's at the highest risk and had cognitive decline. She's done great now for 13 plus years, continuing to do well. So she has written over 100 guides so that people can know, how do I do this? How do I do that? How do I do this? Tremendously helpful. You can literally go on, and the easiest way to get started, just have them go on to MyCQ Test, MyCQ TEST, MyCQ Test. That'll tell you, where do you stand with your cognition right now? Do you need to be treated? Very easy, and it's a free online test. Okay. Then the other one I recommend is go to Get a Brain Scan. That is the p-tau test, getabrainscan.com. Now, if you are going to be treated, if you're going to be part of the community, which is very helpful because you're interacting with you've got town halls, you've got forums for questions, you've got links to well-trained health coaches, links to well-trained physicians, because there are a lot of physicians that are not doing the right things. And we saw in our trial, some groups were getting spectacular results, others are not getting such spectacular results. So you want to get the best ones. So yes, then it's a good idea to sign up. There's a 1-year subscription that can be done. But by the way, we've tried to keep it to minimal cost so that everyone can do this. Dementia is a huge problem in our country. The U.S. spends over $300 billion. It dwarfs the COVID pandemic. COVID pandemic killed over 1 million Americans. Alzheimer's statistically is set to kill 45 million of the currently living Americans. So we want to get that number as close to 0 as possible. So what Apollo provides is community, testing, evaluation, data support, and then continued improvement in the overall outcomes and protocol. And then also publication to share, okay, this is what's working best and this is what's working least. So I do think this is the way to reduce the global burden of dementia.
And so my understanding is that just because I live and I work in New Mexico, I'm in Santa Fe, but it's still a medically underserved area. Our state definitely is. So what I'm interested in understanding is if someone signs up for Apollo, it is possible for them to implement your protocol by
Yes.
working with a health coach and then using the Apollo testing, correct?
And a physician. It'll also direct you. So some people, especially the people who are there for prevention, just want to work with a health coach and say, okay, fine, I can get my testing, I can get this done, I can get things optimized. The coaches are very important. But if they say, look, I also want to have a practitioner and a practitioner team. And of course, many of these teams work together that have a physician, have a health coach, may have a nutritionist, they may have a physical trainer. They've got a whole team together and they're getting fantastic results when they have good teams. So yes, but the trained people, the practitioners, the MDs, the neuropsychologists, the nurse practitioners, the health coaches are all on the Apollo website. So they really have a kind of soup to nuts, everything about what can be done to make sure that you don't develop dementia, or if you're beginning to have problems, to make sure that you have the best chance for reversal of cognitive decline.
Got it. Thank you. Okay, so let's shift gears a little bit because I would like to ask you about the lifestyle advice that you describe in your book.
Yeah.
And I know you've written several books, but I think it's the end of Alzheimer's, right? Sorry, I've read so many books for Alzheimer's in the past month for the summit. I'm getting a little. So you have the basic 7 or the Bredesen 7, the way that it's described in your book. Could we talk a little bit about that? And I don't expect you to go through everything like in a laundry list, but maybe if people really need to choose, let's say if you had to pick 3 or 4 things to prioritize for people who are just wanting to get started and would like to keep things simple, what would you recommend or advise?
Yeah. And so, by the way, the recent book that described the basic 7 was called The Ageless Brain. And it was all about helping everybody to make sure that their brain span is as long as their lifespan. Because as so many people will die at 80, 85, 90, 95, but their brains only work until 70 or 75.
Yeah.
We want to fix that. So we want to make it so that everybody has an opportunity to have a brain span that's equal to their lifespan. And there are things you can do. When you, again, look at this supply and demand for everybody, then what happens is there are 7 basic things, the foundation, and then there are the 2 specifics to get you to make that supply increase and the demand decrease. So the foundational things are.
And Dr. Bredesen, sorry, I'm just going to back you up for a second. And
Sure.
when you say supply and demand, I just want to make sure that we're all on the same page because
Yes.
there are so many things that are encompassed in this, right? They're just like you're talking about oxygen, you're talking about trophic factors. So maybe just give us
So all of the things that supply your brain, and as you say, blood flow, oxygenation, mitochondrial function, trophic support, nutritional support, all of these things are critical. So you want to get these up. And all of the demand side, which is inflammation and toxicity and things like that, you want to get those down. Because what happens is, as we age, and again, the beginnings of this, even in people in their 20s, hard to believe. We always thought of Alzheimer's as old timers disease. We're now understanding that this thing starts much earlier in life. You just get diagnosed much later in life. So when you're looking at that, there are these key pieces that are adding to your demand when you've got exposure to various toxins or inflammagens or things like that. So that's the idea. So the basics are diet, exercise, sleep, stress, brain training, detox, and some targeted supplements. Those are the basic 7. So we want to get you on a plant-rich, mildly ketogenic diet. It's not plant-only, but plant-rich. If you want to do it as plant-only, that's okay too. But the point is you need to be insulin sensitive and you need to be capable of driving ketosis. So you want to be metabolically flexible. That's the goal of the diet part. Then there's exercise, and you want to have both the aerobics and the strength training that I mentioned earlier. Sleep, it's very clear. You have 4 parameters, and I check mine every morning, my Apple Watch, and wearables are really helping a lot of people, or some people like Oura Ring, what have you. What you want to look at is, did you get at least 7 hours of sleep? Did you get at least 90 minutes of REM? Did you get at least 60 minutes of deep sleep? And did you have an SpO2, an oxygen saturation of at least 94%? There was a paper a few years ago that showed remarkably, just looking at your average through the night of your oxygen saturation correlates with the size of your hippocampus.
Wow.
Surprising. If you've got sleep apnea and you're sitting around at 88% at night, you're likely to have a smaller hippocampus, unfortunately. So that's the critical piece of sleep. Stress. I used to think as a scientist that stress was not an issue. Yeah, we all have stress. So having stress and resolving it, that's what we can do that. Humans do that. It's the chronic unremitting stress. Humans do not handle that well. Their brains shrink when they have that for years. So that's what we want to get rid of. And then brain training, brain stimulation overall, V-light therapy, red light therapy, all these sorts of things, brain training. Professor Mike Merzenich, who's the father of brain training, has shown remarkable results with improving cognition with brain training. Again, by itself, it's not as good as doing all 7. Just one at a time, take them and you'll slowly get used to it and you'll notice the difference. And then some detox, basic detox, having a high fiber diet, doing some sweating, doing some exercise. Exercise is actually part of this, is helping, improving your gut microbiome, being exposed to organic things rather than toxic things, finding out if your home is full of mold species that are making brain damaging mycotoxins. It's easy. The EPA years ago set up these ERMI tests. Anyone can do it. You can do it directly from online. It's easy. We checked our own home here. You can see whether you're exposed to these things. And then finally, some targeted supplements. And yeah, things like resolvins can be very helpful if you've got some inflammation. Those are great. And by the way, we found on our trial, a number of people after the trial finished said, I'm not doing more supplements. And they didn't do as well. So in fact, these can be helpful. People will say, that's not a cure for Alzheimer's. Of course it's not. It's part of an overall approach that helps you to reverse cognitive decline. We don't use the term cure. It's helping you to reverse the decline because that's what we've demonstrated, published in peer-reviewed journals. The 2 specifics then are looking at the infections that you may have, and there are many tick-borne illnesses, herpes simplex, P. gingivalis from your oral microbiome, various tick-borne illnesses. All these sorts of things can be a problem. And then the other is toxicity. Are you exposed to these various toxins that I mentioned earlier? So looking at those together and addressing them, that is really what has helped the most. And yeah, it can feel daunting at the beginning. Work with a good health coach and a good practitioner. They'll help you. Just take it at your own speed. This is a chronic illness. It's not an acute illness. So take it at your own speed. And we see it again and again. The cognitive scores go up. People notice improvements. And by the way, they often notice improvements in their general health as well. We have people in the trial, they're coming off their blood pressure pills. They don't need their blood pressure pills anymore. They are coming off things like their statins. They don't need their statins anymore because doing the right things, optimizing your physiology means you don't need those things. And then often they'll also be able to come off their anti-diabetes drugs as well. So this is, again, about physiology. We have to shift the discussion on dementia from pathology to physiology. This is the way the system works. And it's turned out that the pathology is all about how your brain responds to these various insults. This is not what's causing the problem. This is what the response to what's causing the problem actually is.
Got it. That's so fascinating. And there's a question that I wanted to ask you related to mold, because when I spoke with Neil Nathan, we did his interview,
Yeah,
he
good.
had said that he spoke with you and that I just wanted to double check. He had said that you said that around 90% of your patients had mold. Did we get the
Okay.
number right? Could you tell us a little bit about that? Because mold is one of these issues that kind of no one thinks that their house has mold unless they can obviously see it on the wall.
Yeah.
No one wants to, they don't want to address it.
And isn't it interesting? The Alzheimer's disease hasn't even admitted that mold is a cause of cognitive decline. So no, this is not an issue. It turns out it's a very common one. Now, what I talked to the We published an earlier trial and talked to those physicians. Okay, how many of them actually had mold exposure? What we found was about 25% or so have mold as the dominant thing. That's the major thing it's outstripping everything else. They have that syndrome I talked about with the depression coming first, the dementia, the non-amnestic presentations. Often it's women in their early 50s. It's around the time of menopause. That sort of thing is about 25% or so of the trial. But if you look at the various contributors, most people will have some degree of insulin resistance. Most people will have a little inflammation. And it does turn out the vast majority, yes, about 90% of people, as Neil said, and by the way, we work with Neil frequently with patients. He's really such an expert, a global expert on these various syndromes associated with both tick-borne illnesses and mycotoxin. Of course, he's written a number of wonderful books, such as Toxic, Heal Your Body, and others. The Sensitive Patient's Guide to Healing is another one I really like from him. So he's done a fabulous job. And when you look at this, yes, most of these people have significant exposure. Now, part of this seems to be no matter what happens to them, over time, they lose their ability to detox. So any mold species, any mycotoxins, they're going to accumulate them. So it can be a primary, it can be a secondary. But at least as part of the overall contribution, yes, about 90% of the people that we see with cognitive decline will have some degree of mycotoxicity.
And I don't know if you can answer this question, but I'm just wondering, from all of the foundational things, the Bredesen 7 or other components that are contributing to cognitive decline, are there a few that stand out as when you treat them, you get the greatest response across the board, or it is entirely related to the person and their type?
It's going to be different from person to person. For some people, it's really a metabolic problem largely. They heal their metabolic syndrome, they're going to get better. But if you do that and someone's got the major problem is severe exposure to toxins, that's not going to do it. Now, we do have something we call Burke's Law. I named this after Christine Burke because she pointed out that if you just do the basics for everybody, it buys you about 9 to 12 months. People do better. But during that time, then you got to be looking at what's actually causing it. If you don't find what's causing it and address it, after 9 or 12 months, they're going to go downhill again. But at least it gets you some improvement. And we've had people even 4 or 5 years before they have a secondary decline if you don't find what's actually driving it. So if you had to do just a few things, the things that are most powerful initially are the metabolism. So doing the what we call KetoFlex 12-3 diet. So it's a plant-rich, mildly ketogenic diet. Exercise, regular exercise. And I don't mean just walking, getting your heart rate up, doing strength training as well as aerobics or HIIT, for example. You can even consider EWOT that I mentioned earlier, exercise with oxygen therapy. That's probably the most beneficial. And then the third one being the sleep parameters, making sure that you don't have sleep apnea. Sleep apnea is a very common contributor to cognitive decline. So if you had to do just 3, it would be those 3. But those 3, then the people who really have a lot of toxicity are in the long run not going to get that, which is why, again, we want to look broadly and find all the contributors. Typically, people we see with cognitive decline have between 5 and 15 different contributors. So we want to hit these to get the best outcomes. But again, you can start with those 3, and most people will do very well. I should mention that includes getting people into ketosis. So I just recommend at the beginning, just take for the first couple of weeks until you're able to get into ketosis. Or if you don't have fat to burn, just take exogenous ketones. Take some ketone salts or ketone esters, or even some organic coconut oil. Dr. Mary Newport did such a great job with her own husband who had Alzheimer's disease. And she showed that just giving him coconut oil so he would get his ketones up, which gives more energetic support for your brain, actually improved him. And of course, Professor Stephen Kinane from Canada, I think we're still allowed to talk about Canada, right? Despite all the tariffs and the back and forth. Our wonderful neighbors, Canada. I really appreciate Canada and all the good things they've been doing. And Professor Stephen Kinane is a wonderful Canadian who did a trial where he just gave his patients ketones. And in fact, they did better. So
Really?
having that energetic support, which comes from glucose and ketones, so you got to be insulin sensitive. You got to be able to either take or make ketones. Very helpful for your brain's energetics. So those would be the top three.
That's great. Thank you so much, Dr. Bredesen. So I want to be respectful of your time. So I'm going to ask you one last question, which
Okay.
is there anything that I should have asked you or that you want me to ask you? What would you like to leave our audience with? What do you think is important for people to know who are just getting started on this journey?
Yeah, I think the most important thing for people to know is that the world has changed. We all remember when the first time you were able to do a Google search, it was like, wait a minute, I can look up all this stuff now. Remember the first time you used AI? You looked up something and it gave you an answer that was a quick AI answer, or the first time you used Chat GPT. These are world changes. Suddenly you can do stuff you couldn't do before. We are in the same sort of era change when it comes to cognitive decline. We've been told for years nothing can be done, just sit there and wait for it. There's just nothing there. The reality is very few people should get cognitive decline. So please, everybody, if you're 35 years of age or older, get a simple evaluation, go to my CQ test, see where you stand, get your p-tau 217 checked. There doesn't have to be this huge number of people developing cognitive decline. There is so much. The armamentarium for this problem has grown by leaps and bounds. When I was training way back in the 1980s, we had nothing to offer people with dementia. Now, people don't need to wait until they have dementia. Get in as prevention or get in when you have the earliest subjective cognitive impairment. Go to someone who's had a good track record. Ask them, have you reversed decline in people? Maybe talk to one or two of them to make sure, and then get on an optimal program. And let's make sure that very few people ever develop dementia. That's the paradigm change in this whole field.
Dr. Dale Bredesen, thank you so much for joining us on the Healing Dementia Summit. And I want to thank you personally for all of your massive contributions to science, to the literature, and also to the field of dementia reversal, really. That's really what you're doing. It's so incredible. So thank you.
Thank you, Dr. Goldberg. Great to talk to you.
Thanks. And to all of our listeners, thank you so much for joining us. And I'll see you in the next session.